Hi, I'm Dr. Tracy Marks, a psychiatrist, and I make mental health education videos. Today, I'm talking about two different presentations of bipolar disorder, a classic or textbook presentation and a non-classic or atypical presentation. And these are not official subtypes of bipolar disorder that you'll find in the diagnostic manual. This is a clinical description of two different ways that bipolar disorder can present or look. This matters because the classic form of bipolar disorder tends to respond much better to lithium, and the atypical form tends to respond better to anticonvulsant mood stabilizers like Depakote or lamotrigine, and the atypical antipsychotic medications like Abilify or Seroquel. I use and define a lot of terms in this video, and I think it's good for you to know the clinical terms, so if you're listening to someone else talk about this, or you're reading about it online, you'll understand what's being said. And sometimes when your doctor's talking to you, he or she can slip into these terms without thinking about it because it takes some extra work to do the translation in your head to speak using non-clinical jargon. I'll review the terms at the end of the video. So going back to the atypical antipsychotics, they're called atypical because they block dopamine and serotonin, whereas the older antipsychotics like Haldol block dopamine only, and they're considered the first generation of antipsychotics focused only on treating psychosis. Then in 1990, the first of the second generation antipsychotic medications started with clozapine. And these are antipsychotics that are mostly used today, especially in treating bipolar disorder and treatment-resistant depression. Here's a comparison between classic bipolar disorder and atypical bipolar disorder. When it comes to hypomania and mania, with classic bipolar disorder, you start with euphoric or happy or grandiose mania. As you age, though, your manias can become more irritable, but it starts out bright. With atypical, you predominantly get dysphoria or dark moods. You can also get mixed states. A mixed state is where you get a mixture of depression and mania occurring at the same time. I talk about it in more detail in this video that I did on mixed mania. With classic bipolar, you get full recovery between episodes and can have long stretches in between episodes. So when you're not having an episode, you're back to your baseline state, and that can last for months or years before you have another episode. With atypical, you tend to have these leftover symptoms of a lesser intensity in between episodes, so it may not feel like you ever really got out of your last depression. Things got better, but not all the way better, so you don't feel like you ever got back to the way you were before you got sick the first time. And as far as terms go, the clinical term for the leftover symptoms is subsyndromal. These are symptoms that are not as severe enough to be diagnosed as an illness or a syndrome all by themselves if you just look at them in isolation. But in this case, they're remnant symptoms of your bipolar illness. Rapid cycling is having more than 4 episodes in a year and is more common with atypical bipolar disorder and rare with the classic form. With classic, you don't tend to have other disorders like anxiety, addictions, or OCD. And these other illnesses are called comorbidities because they co-occur with other illnesses. Morbidity or morbid is a clinical term for disease state. So if you ever read online or hear someone refer to your pre-morbid state, it's how you were before you were ill. And if you have several illnesses like ADHD, anxiety, bipolar disorder, etc., all of these illnesses are considered comorbidities. So we tend to think of classic bipolar as being more pure and not affected by other illness. The age of onset of classic bipolar disorder tends to be around age 15 to 19. And for atypical, it's earlier, like ages 10 to 15. Generally, psychiatric illnesses that start to take shape in a defined way in childhood end up taking on a more severe form in adulthood. It's like the illness has more time to gain momentum and become a stronger version of itself. As for personality style, with classic bipolar disorder, people tend to have either a normal personality that doesn't cause much problem, or what's called a hyperthymic personality. Hyperthymic is a term we use to describe someone who has naturally high energy, a people person, or tends to be a leader. With atypical bipolar disorder, you see more personality disorders like borderline personality disorder or cyclothymic temperament. I talk about the combination of bipolar disorder and borderline personality disorder in this video. Cyclothymic temperament is a psychological construct and not a diagnosis. A construct is a concept or theory that someone develops. Your temperament refers to your hardwiring that you're born with. With cyclothymic temperament, you're hardwired to be more moody and emotionally reactive. This reactivity comes from being more interpersonally sensitive. The last comparison is genetics. With classic bipolar disorder, there's a clearer history of someone in the family having bipolar disorder. Not everyone has a family history of bipolar disorder, but many do, since it's strongly heritable, another term. Heritable means capable of being inherited or passed down to another generation. And in psychiatry, the two most heritable disorders that we have are bipolar disorder and schizophrenia. If you have a first-degree relative with this illness, it's not a given that you'll get it, but you have a higher chance than someone who does not have a relative with it. A first-degree relative would be someone who shares half of your DNA, like a parent or a sibling, not a cousin or an uncle. So with classic bipolar, it's more common that you have bipolar disorder in the family. With atypical bipolar disorder, the family history is a little murkier. There may be relatives who have other disorders like depression, schizophrenia, or other illnesses. Psychiatric illnesses in general can run in families such that if you have an uncle with schizophrenia, you could end up having depression. You didn't inherit the same illness as your uncle, but you have a different mental disorder. As it turns out, the classic bipolar picture is less common than the atypical presentation, even though the word atypical makes it sound like it's not that usual. It's called atypical because when the German psychiatrist Emil Kraepelin first discovered bipolar disorder, which at the time he called manic depression, it was the classic form that he first defined. Later on, this other variation became recognized. So it's similar to the antipsychotic story. The newer second generation of antipsychotics are called atypicals, and they're a spinoff of the older ones. But they are the ones that are more commonly used today. But the main significance to recognizing these differences is that classic bipolar disorder tends to be more responsive to lithium. And lithium has a lot of benefits, including being neuroprotective, which means it protects the nerve cells in your brain from injury and degeneration. Despite the fact that lithium has a lot of side effects, making people feel as though they're cognitively slowed or dulled, lithium has been shown to have benefit in preventing dementia. But it's not always an easy drug to take and has other significant side effects. That said, if you have a more atypical presentation to your bipolar disorder, you will probably get better results with the anticonvulsants and the atypical antipsychotic medications. So to recap, here are the terms I discussed today. Classic bipolar, atypical bipolar, atypical or second-generation antipsychotics, subsyndromal, morbidity, psychological construct, hyperthymic temperament, heritable, first degree, and neuroprotective. That's a lot of stuff. If you want to get used to hearing the jargon and understanding it, watch the video again. For more information on taking lithium, watch this video. See you next time.